Before you're diagnosed with diabetes, your feet will show these 6 warning signs. The body speaks first, why your feet know before your doctor does. Carol almost missed it entirely. She was sitting on the edge of her bathtub one Sunday evening in late October, trimming her toenails the way she had done every few weeks for the past 60 years, when she noticed something that made her pause. The bottom of her left foot, the heel specifically, felt different under her fingers. Not painful, not swollen, just less there, like she was touching someone else's foot through a thin rubber glove. She pressed harder. The sensation was muted, distant. She told herself it was nothing. She was 61, a retired school librarian from Raleigh, North Carolina, and she had spent 4 decades on her feet. A little numbness was just part of getting older. That was what she believed. She kept believing it for 8 more months until a routine blood test at her annual physical revealed a fasting blood sugar of 218 milligrams per deciliter, and a doctor sat across from her with an expression she would never forget, telling her she had type 2 diabetes. Not prediabetes, not borderline. Diabetes fully arrived, already at work in her body. "How long has this been developing?" she asked. Her physician, a diabetes specialist named Dr. Angela Foster, looked at her carefully and asked a question Carol was not expecting. "Have you noticed any changes in your feet in the past year or two? Tingling? Numbness? Skin changes? Anything unusual?" Carol thought about the bathtub, about the muted heel, about the times she had noticed her feet felt odd in the morning, a faint buzzing sensation she had attributed to the way she slept, about the small patch of dry, thickened skin on the ball of her right foot that had appeared sometime the previous spring and simply never went away. "Yes," she said slowly. "Actually, yes?" Dr. Foster nodded. She had heard this many times before. "Your feet," she said, "were trying to tell you for at least a year, possibly 2. The signs were there. We just didn't know to look for them." This is the conversation that happens every day in diabetes clinics across America. The retrospective recognition that the body had been sending signals long before any blood test confirmed the diagnosis. That the feet, in particular, had been broadcasting a warning in a language that most people, and even many physicians outside of diabetes specialty care, do not instinctively know how to read. Type 2 diabetes does not arrive like a sudden storm. It builds like a slow tide, rising incrementally over years, touching the most vulnerable parts of the body first and often quietly. By the time a standard fasting blood glucose test crosses the threshold into diabetic territory, the disease has typically been progressing for 5 to 10 years. The blood sugar has been elevated, not at diabetic levels, but above optimal for much of that time. And during those years, the damage has been accumulating in the tissues and nerves that are most sensitive to blood sugar dysregulation. The feet are first for a reason that is rooted in simple anatomy. The nerves that serve the feet are the longest nerves in the human body. A nerve signal traveling from your lower spinal cord to the tip of your big toe must traverse a distance of roughly 3 to 4 feet, the longest single nerve run in the body. Long nerves are metabolically expensive to maintain. They require constant nutritional support from tiny blood vessels called capillaries that run along their length. And high blood sugar, even at the subtly elevated levels that precede a formal diabetes diagnosis, damages both those capillaries and the nerve fibers they feed. This is the process called peripheral neuropathy, and it begins in the feet, in the toes, and the heels, the farthest points from the body's core before it moves anywhere else. Simultaneously, elevated blood sugar damages the small blood vessels that supply the skin of the feet with oxygen and nutrients. The skin becomes less able to repair itself. Circulation slows. The immune cells that normally patrol the skin's surface in enormous numbers begin to thin out. The feet become vulnerable in ways that have nothing to do with how they look on the outside. The result is a constellation of 6 warning signs that, taken together, constitute one of the most reliable early warning systems the human body possesses for prediabetes and undiagnosed type 2 diabetes. These signs appear on average 1 to 3 years before a formal diagnosis, sometimes longer. They are not subtle to someone who knows what to look for. They are hiding in plain sight on the body part that most Americans over 50 examine least carefully. Until now, you are going to know exactly what to look for. There, the 6 signs, what your feet are trying to tell you. There is an order to these signs, not a strict sequential order in which every person experiences them, but a general progression that reflects the underlying biology. The signs that appear earliest tend to be the subtlest, the ones most easily dismissed. The signs that appear later are more visible, more dramatic, and unfortunately further along on the timeline toward confirmed disease. Read all 6. Check your own feet when you are done. And if you recognize more than 2 of these signs in yourself, make an appointment with your doctor and ask specifically for a comprehensive metabolic panel and HbA1c blood test. Not just a routine blood pressure check, a fasting glucose and a 3-month blood sugar average. Those 2 numbers together tell a story that a single screening cannot. The warning sign, one tingling or buzzing that comes and goes. This is typically the first sign, and the one most reliably dismissed as insignificant. It feels like pins and needles, like the foot has fallen asleep, except you weren't sitting in a position that would cause that, or like a faint electrical buzz in the toes that arrives without warning and disappears after a few minutes. Some people describe it as a vibration. Others say it feels like carbonation, like tiny bubbles moving through the skin. The medical term is paresthesia. It occurs because the small nerve fibers in the feet, the ones responsible for light touch sensation and temperature detection, are the first to be affected by high blood sugar. These thin fibers have a protective coating called myelin, and elevated glucose gradually damages this coating, disrupting the nerve's ability to transmit signals cleanly. The result is spontaneous, misfiring electrical activity, the body's equivalent of a loose electrical wire sending random sparks. The tingling tends to be worse at night, when the distractions of the day are gone and a person is lying still in a quiet room, paying attention to what the body is doing. Many people interpret it as poor circulation from the way they are lying, or as a sign of tiredness. They adjust their position and go back to sleep. They do not connect it to blood sugar, but consider this: tingling in the feet that appears at rest, that is not clearly related to body position, and that recurs regularly over weeks or months, is one of the earliest and most reliable flags of early peripheral neuropathy. In multiple studies examining patients who were eventually diagnosed with type 2 diabetes, this symptom appeared, on average, 18 months before diagnosis. 18 months of warning in the toes. Every night, waiting to be recognized. Warning sign 2, numbness that doesn't fully go away. The next stage follows the tingling, sometimes months later, sometimes years. It is the transition from too much sensation to too little. As nerve damage progresses from the misfiring of early neuropathy to more established damage, some fibers stop transmitting signal altogether. The result is patches of reduced sensation, numbness, that persist even when the foot is in a normal position, well rested and well circulated. Carol's muted heel was this sign. She pressed her fingers into it and felt less than she should have. The sensation was there, but attenuated, like listening to music through a wall. The numbness typically begins at the tips of the toes and the heel and works its way inward and upward in a pattern called the stocking distribution, so named because it covers the foot and lower ankle in roughly the area that a sock or stocking would cover. This pattern is distinctive in medicine. When a physician sees numbness in this distribution, it points almost immediately toward peripheral neuropathy as the cause. One critical and frightening consequence of this numbness is that it removes a fundamental protective mechanism. Pain is the body's alarm system. When you step on something sharp, when your shoe rubs a blister, when a small cut becomes infected, pain is what makes you stop, look, and respond. Without pain, injuries go unnoticed. Small wounds become large wounds. What should be a minor inconvenience becomes a serious medical emergency. This is the reason that foot wounds and foot amputations are so devastatingly common among people with advanced, uncontrolled diabetes. It is not that diabetes makes wounds heal poorly, though that is also true. It is that the wounds happen silently, without warning, and are not discovered until they have already become severe. Catching numbness early, before it becomes the kind of established neuropathy that allows injuries to go unfelt, is one of the most important gifts you can give your own future health. If you press on the bottom of your foot and the sensation is noticeably less on one foot than the other, or less than it used to be, that asymmetry and that change deserve medical attention. Warning sign 3, feet that are always cold, even in a warm room. Here is a sign that surprises many people, because they have always assumed cold feet are simply a matter of personality, or thin blood or bad circulation in a general sense. And while all of those things can contribute to cold feet, there is a specific pattern of coldness that is associated with prediabetes and early diabetes that is worth understanding precisely. The small blood vessels, capillaries, and arterioles that supply the skin of the feet with warm, oxygenated blood are among the first vascular structures damaged by elevated blood sugar. High glucose causes a process called glycation, where sugar molecules attach to proteins in the vessel walls, stiffening and narrowing them. Blood flow slows, less warm blood reaches the skin's surface. The foot feels cold to the touch, even when the rest of the body is warm. The diagnostic distinction that matters, cold feet related to early vascular damage from elevated blood sugar, are typically cold in a specific pattern. The toes and the ball of the foot are often colder than the top of the foot and the ankle. When you touch the skin, it may feel not just cool but slightly waxy, a texture that reflects reduced skin hydration from impaired circulation. Furthermore, the coldness does not respond normally to warming up. Put on warm socks, wrap the feet in a blanket, sit near a heater, and feet with normal circulation warm up within a few minutes. Feet with compromised microvascular circulation warm more slowly and unevenly, and the toes may remain noticeably cooler than the arch even after extended warming. Men and women over 50 who notice that their feet are persistently cold. Cold in ways that differ from how their feet felt a decade ago, and cold in a way that resists normal warming. That pattern deserves attention and a conversation with a physician. Warning sign 4, dry, cracking skin that appears without explanation. This is the sign that sits in the most visible plain sight of all, and is perhaps the most universally dismissed as cosmetic rather than medical. Dry skin on the feet, cracking heels, thickened, rough patches on the ball of the foot or the sides of the toes. In a country where foot care products fill entire pharmacy aisles, and where dry heels are commonly attributed to seasonal weather, hard floors, or simply genetics, it is almost impossible to imagine that this ordinary-seeming problem could be a medical warning signal. But there is a specific pattern of foot dryness that is linked to developing blood sugar problems, and it is worth knowing. The sweat glands in the feet are controlled by the autonomic nervous system, the branch of the nervous system responsible for automatic, unconscious body functions. When peripheral neuropathy begins to affect the autonomic fibers in the feet, one of the earliest consequences is reduced or absent sweating. The feet lose their natural mechanism for staying supple and moisturized. The skin becomes dry from the inside out, not because of environmental dryness, but because the body's own lubrication system has been disrupted. This neurologically driven dryness has a particular character. It tends to be persistent regardless of weather or season. It does not respond as well as typical dry skin does to moisturizing lotions. The underlying dysfunction continues even when the surface is temporarily hydrated. It concentrates in the heel and the ball of the foot, areas of high pressure and friction, and it can progress to cracking, fissures that break the skin's surface and create entry points for bacteria. In people with elevated blood sugar, even small breaks in the skin of the foot are medically significant. The immune response that normally rushes to seal a wound and fight infection is impaired by high glucose. White blood cells become less mobile and less effective in high sugar environments. What would be a minor nuisance for someone with normal blood sugar can become a serious infection for someone whose glucose has been elevated for years. The practical check: look at your heels. If the skin there is consistently cracked, not just rough, but genuinely fissured, with cracks that deepen over time, and if you have noticed this pattern persisting for more than a few months, it belongs on your list of things to discuss with your doctor. Warning sign 5, slow healing cuts, blisters, or sores. This sign moves from neurological and vascular to immune, and it is the one that most clearly illustrates how multiple systems are affected simultaneously when blood sugar is chronically elevated. A small cut on a healthy foot heals through a precise, orchestrated process. Within seconds of injury, platelets begin clotting. Within hours, inflammatory cells arrive to clean the wound. Within days, new tissue begins to form, a process called granulation. Within weeks, the wound is sealed and the skin is rebuilding its full integrity. Elevated blood sugar disrupts this process at almost every step. The blood vessels that should rush new tissue-building cells to the wound site are already narrowed and stiffened by glycation. The white blood cells that should fight bacteria are less mobile in a high glucose environment. Sugar literally interferes with their ability to move through tissue. The collagen that new skin needs to form is produced more slowly when insulin signaling is impaired. And the nerve damage that accompanies early neuropathy removes the pain signal that would normally make a person protect the injured area and keep it clean. The result is wounds that linger. A blister from a new shoe that should heal in a week takes 3 weeks. A small cut from a sharp toenail edge that should close in days remains raw and red for 2 weeks. A friction sore that appears after a long walk simply does not go away. If you are over 50 and you have noticed that minor foot injuries are taking longer to heal than they used to, not dramatically longer, not alarmingly longer, just consistently, noticeably longer, that change in wound healing speed is a clinically meaningful signal. Keep a mental note of the next time you get a small cut or blister on your foot. How long does it take to fully close and heal? If the answer is longer than 2 weeks for a wound that seems minor, that timeline belongs in a conversation with your doctor. Warning sign 6, changes in skin color, redness, paleness, or dark patches. The sixth sign is the one that most directly reflects what is happening inside the blood vessels. And it is also the most varied in its presentation, which is why it often confuses people or gets attributed to causes that seem more plausible. There are 3 distinct color changes worth knowing: persistent redness or warmth in the foot or ankle. When the small blood vessels in the feet are damaged and the autonomic nervous system loses its ability to regulate blood flow precisely, the vessels can become chronically dilated, stuck in an expanded state that pools blood in the foot. The foot appears redder than normal, feels warmer than the skin above it, and may have a slightly swollen appearance even without any specific injury. This is not infection. It is vascular dysregulation driven by early autonomic neuropathy. Pallor, unusual paleness when the foot is elevated. Raise a healthy foot above heart level, and it may pale slightly. Lower it, and color returns within seconds. In a foot with compromised circulation, the pallor on elevation is more pronounced. The foot may turn nearly white, and the color return on lowering is slower, sometimes taking a minute or more. This is called dependent rubor and elevation pallor, and it is a clinical test that physicians use to assess peripheral arterial disease, a condition that develops in parallel with and is strongly linked to diabetes and prediabetes. Dark patches, especially around the ankle and toes, these can represent hemosiderin deposits, iron from red blood cells that have leaked out of damaged capillaries and deposited in the surrounding tissue. The patches are typically brownish or reddish brown, irregularly shaped, and do not blanch when pressed. They are a sign that the capillary walls have been sufficiently damaged by elevated blood sugar that small amounts of bleeding are occurring under the skin on a regular basis. Any of these color changes, persisting without obvious injury or explanation in a person over 50, deserve a conversation with a physician and a blood sugar assessment. Part 3, What to do right now, the steps that can change everything. Carol left Dr. Foster's office that day with a diagnosis she had not anticipated and a regret she could not quite name. Not regret about the 8 months since the bathtub, she had not known what the muted heel meant. The regret was vaguer and wider than that. It was the feeling of wishing someone had told her years earlier that her feet were worth paying attention to in this particular way. She is telling you now. Because the most important thing to understand about these 6 warning signs is what they represent in terms of time. They are not signs of diabetes that has already caused irreversible damage. They are signs that appear while the window is still open, while blood sugar is elevated enough to be doing damage, but not yet elevated enough to have done the damage that cannot be undone. The medical evidence on this point is clear and consistent. Prediabetes is reversible. Early type 2 diabetes, caught soon enough and addressed aggressively with lifestyle changes, can be sent into remission in a significant percentage of people. The nerve damage of early neuropathy can stabilize and, in some cases, partially reverse when blood sugar is brought back under control before the damage becomes severe. The window does not stay open forever. But for most people reading this, it is still open. Step 1, examine your feet tonight. Not tomorrow. Tonight. Sit somewhere with good light. Remove your socks. Look at the entire surface of both feet and top, bottom, sides between the toes, the heels. Run your fingers along the sole. Press gently in several places and notice whether the sensation feels the same on both feet and whether it feels as clear and immediate as it should. Ask yourself honestly whether you have noticed any of the 6 signs in the past several months, not whether they are dramatic, whether they are present. If you notice anything, any persistent tingling, any patches of diminished sensation, any unusual dryness or skin changes, any color variations that you cannot explain, write it down, date it. Note which foot, which area. This documentation will be useful when you speak to your doctor. Step 2, make the appointment and know what to ask for. If you are over 50 and you have not had a comprehensive blood sugar assessment in the past year, that appointment should happen regardless of whether you recognize any of the 6 signs. When you call, ask for a fasting blood glucose test and an HbA1c test. The HbA1c, glycated hemoglobin, measures your average blood sugar over the previous 3 months. It cannot be gamed by one good day of eating before the blood draw. It tells the truth about what your blood sugar has been doing. If you recognize 2 or more of the 6 signs in yourself, tell your doctor specifically. Say, I have noticed what I believe may be early signs of peripheral neuropathy in my feet. I would like a comprehensive evaluation including blood sugar assessment and, if appropriate, a neurological foot exam. Those words will be understood immediately and will ensure your concerns are taken seriously and followed up completely. If your doctor finds that your blood sugar is in the pre-diabetic range, fasting glucose between 100 and 125, or HbA1c between 5.7 and 6.4%, ask for a referral to a diabetes prevention program. The CDC recognized National Diabetes Prevention Program has been shown in rigorous clinical trials to reduce the risk of progression from prediabetes to type 2 diabetes by more than 58% in people who complete it. That number deserves a moment of consideration. More than half of prediabetics who go through this program do not develop diabetes. Step 3, begin protecting your feet now. Whether or not you have any of the 6 signs, the following foot care practices reduce the risk of developing the complications described in Part 2 and protect against their worsening if any early signs are already present. Inspect your feet daily. Every day, briefly, you should look at the entire surface of both feet. This takes 2 minutes. It catches injuries, infections, skin changes, and blisters before they become serious. For people with reduced sensation in the feet, this daily inspection replaces the pain signal that would normally alert them to a problem. Wear properly fitting shoes. Shoes that are too tight, too loose, or that create pressure points are the most common cause of foot injuries in older adults. Feet change shape with age. They widen, they flatten slightly, the fat pad on the sole thins. Shoes that fit well at 40 may not fit well at 60. Have your feet measured properly when buying shoes and prioritize fit over appearance. Keep the skin of your feet moisturized. A fragrance-free lotion applied to the heels and soles, not between the toes where moisture can encourage fungal growth, daily after bathing helps maintain skin integrity and reduces the risk of cracking. This is more important than most people realize in the context of blood sugar management, because intact skin is the first line of defense against infection. Never go barefoot outside, and be thoughtful about going barefoot indoors. Hard floors, small objects on the ground, temperature extremes, all of these create injury risks that are magnified by reduced foot sensation. Protective footwear indoors is not excessive for someone who has noticed reduced sensation in their feet. It is rational. Walk. 30 minutes of walking daily, even at a moderate pace, improves peripheral circulation, supports insulin sensitivity, and has been shown in multiple studies to slow the progression of peripheral neuropathy in people with prediabetes and early diabetes. The feet that carry you are supported by movement. Movement is the medicine. Step 4, take the metabolic threat seriously starting today. The 6 warning signs in your feet are not the disease. They are the signal that the conditions creating the disease have already been building for some time. Responding to the signal is what determines what happens next. Blood sugar is primarily regulated through 3 levers: diet, physical activity, and stress management. All 3 are modifiable. All 3, when addressed together, produce results that can meaningfully shift a person's trajectory away from diabetes and toward lasting metabolic health. Diet, reducing refined carbohydrates, white bread, white rice, sugary beverages, ultra-processed snack foods, and replacing them with vegetables, legumes, whole grains, lean protein, and healthy fats consistently reduces blood sugar and improves insulin sensitivity in people with prediabetes. You do not need a perfect diet. You need a meaningfully better one. Small, sustained changes outperform dramatic overhauls that last 3 weeks and then collapse. Physical activity, beyond the walking already mentioned, any form of resistance exercise, lifting weights, resistance bands, body weight exercises, is particularly valuable for blood sugar management because muscle tissue is the body's largest consumer of glucose. More muscle means more glucose is pulled from the blood after every meal, reducing the spikes that drive progressive insulin resistance. Even 2 sessions per week of light resistance training produce measurable improvements in blood sugar control. Sleep. As research continues to accumulate, the connection between sleep quality and blood sugar regulation becomes harder to ignore. People who sleep fewer than 6 hours per night show significantly higher rates of insulin resistance and prediabetes than those who sleep 7 to 8 hours. Prioritizing sleep is not indulgence. In the context of blood sugar management, it is medicine. Stress management. Chronic stress elevates cortisol, which raises blood sugar through the mechanism described in earlier discussions of this topic. Men and women over 50 who carry high chronic stress loads show measurably worse blood CU,